senator was wrong on that, but I'm kind of curious what happened to that starting point in the process.
Ellen Marie?
I guess I would just say that I think it was one of the things that there was an attempt, believe it or not, to change as few things as possible, to make it be more politically sound and politically able to go through. And changing the way that we now fund employer-based insurance was, or the tax treatment of that, was something that I think was seen as maybe rocking the boat too much. You heard President Obama say over and over again, if you like what you have, you can keep it. And this assurance that the way things are built right now will not change. So I think that by going forward with the current way that, now that may not be the right policy decision, and I think some would say if you're starting to do healthcare reform, maybe none of this would be the right policy, pure policy, but in an attempt to see what can we do in this political climate, and I think as Kavita points out, there was at one point trying to make this be bipartisan and try to have as few changes as possible. I think that may have been one of the decisions to keep moving ahead with that, with the tax treatment the way it was.
Another interesting thing that has come up throughout this debate, and I would say that within the administration, Peter Orszag is someone who kind of beat the drum pretty consistently, had to do with cost containment in our healthcare system. And President Obama did, in fact, run in the campaign largely by promising that he was going to save the average American, I think $2,500 a year, which I look forward to that. But who on the panel can speak to what cost control measures are in the legislation, and what more do we probably need to think about going forward? Because I think there's a consensus it probably won't solve all of our problems.
I'll just highlight a couple, since you brought up Peter Orszag, a couple of the pieces of the bill that Peter and the president, especially, as well as Larry Summers and a number of his economic advisors, really pushed strongly was the Independent Payment Advisory Board, which will in time have the ability as a presidentially appointed panel to make sure that we're actually bending the cost curve, unlike the Medicare Payment Advisory Commission, which every year turns out high quality recommendations that often just end up on bookshelves. The Independent Payment Advisory Board has a number of mechanisms to actually have authorities over which to change the spending on our healthcare system. And then the second piece that not just Peter, but a number of people even prior to the president had really championed was this idea of making a more robust Medicare and Medicaid innovation program. So how can we actually look at the delivery system in a different way, in a different lens, and do something that is not the status quo, but can actually bring us some cost savings? And so I just push out those two pieces.
And the Medicare Commission, just to be clear,
Yeah.
would operate similar to the base closure commissions?
Right. So that's the BRAC, the Base Relocation Authority Commission, which would have kind of an up and down vote ability, and in time the ability, which I think is the part that's the significant authority, to override Congress, or would require a significant congressional activity to override its authority.
We've taken a look at some of the cost projections, and I guess would just continue to be a little skeptical, CC, in part because the demographics of the country, we're an aging country, not quite as bad as China or Japan or Portugal, but the demographics are such that we're going to have an increasing number of baby boomers who are entering and using the healthcare system. And we also have the positive impact of technology, which enhances productivity and efficiency, and hopefully we will have vibrant pharmaceutical companies that will and device manufacturers that will continue to provide new medical treatments. But when you actually look at the numbers, and this is from our chief economist, the annual budget deficit about 10 years from now is projected to be about 7% of gross domestic product and rising. And the Congressional Budget Office projects that the net savings from the health reform bills in the second 10 years out will be about 0.5% of GDP, and much of that most likely is not going to come from improvements in efficiency of medicine, but from non-health policy changes like tax increases. So you put this together and you come away with the conclusion, I think not a partisan conclusion, a conclusion that the bill has not addressed the budget problem in any meaningful way. And so what are we going to do 10 years out when the demographics are worse and hopefully the medicine is better, but not necessarily more cost efficient?
Before I get to Ellen Marie, Charlie, do you have one or two favorite cost containment proposals that you would have liked included in the bill?
Well, I think I would have liked personally, I would have liked a change in the tax treatment, because that's the biggest. If you want to change incentives, you have to do things which change behavior. And right now, we have a system, it's been alluded to, that is primarily, for most people, fee-for-service, and it values volume as opposed to value. And I hope that the reforms in place will change that, but I don't see enough of the type of incentive-based changes to push the system in that direction. I still think it is volume-oriented. I agree with you totally. Whatever's there in terms of dealing with things like obesity and prevention and better nutrition and preventive care, I think are absolutely vital, but I think that's a small part of it.
I agree with Charlie that we have to look at behavior change, but what I'm proud about this bill is it's the behavior change of the providers and the doctors, and not necessarily the behavior change of patients going through it. And I think the part of the tax treatment would look at how patients choose to go into the healthcare delivery system. The bottom line is you go to see a doctor and that doctor says you need to get a CAT scan. You're probably going to get the CAT scan. You're not going to necessarily, and the problem is we need to change the behavior of the providers who now are incentivized to offer more tests, to more is usually better, and the problem is we have unnecessary hospitalization, which is extraordinarily expensive. We have lots of different things that are just rising the healthcare costs as opposed to making the patients better. And what I think, and as Cece points out, that I think pretty much every major idea that would really look to help decrease cost over time are included in here. And there's two ways of doing it. You could have market reform, you could have government reform. And we could have done government reform where we flipped a switch and had payment reform. And imagine how that would have played. We didn't do that. So what we've done is we've got some government suggestions, some government innovation, if you will. So what I think my favorite thing in this bill is the fact that the Centers for Medicaid and Medicare are putting an innovation center in. And they will allow folks, providers who come together and say, here's how I would like to be paid for the service if I can show that I can improve outcomes while I'm decreasing cost. Now, it's true, it's only an incentive, and I'm not sure that there's enough incentives to move from the current fee-for-service to this new way. But what I can tell you is that the fact that that is out there I think is going to help make the physicians and the hospitals start looking at providing care differently. It's the threat of government control. And the fact that we are looking to pay for outcomes, pay for decreasing cost, and new models. The other important thing about this center at CMS is that they don't have to go back to Congress to get approval to make a change. CMS can look at ideas, can move on those ideas, and when they are successful, can expand them. And that has been a big problem with the way we've done healthcare payment reform in the past, that you did a 3-year model, and then you had to go back to Congress, and they then had to vote it in again. So the fact that we're moving some of that control, moving the way we're going to ultimately pay for it, I think that's one of the things I think CBO underestimated. I think that if we can start to have doctors, hospitals, other providers start to deliver care with a different incentive in mind, that's what's going to long-term change the way we're managing aging. I think you're right, it's the aging issue. 70 to 80% of our healthcare dollar goes to managing chronic care, and many of those chronic care, if you're hospitalized, that's a failure in the system. We should be able to do that outpatient. So moving towards managing that care, I think, is where we're ultimately going to see the cost savings.
I think we have a couple of microphones floating around in the room. I have plenty of questions, but why don't we get to some of yours? Sir, I saw your hand go up right away. Let me see if we can get this microphone, and if you don't mind introducing yourself, that would be lovely.
My name is Richard Lewis. I am recently retired. I live in McLean, Virginia, which is also part of my question. I had several questions that I wanted to ask. I'm going to address the last issue first with respect to cost. I'm friendly with a couple of doctors, and I've done some consulting for a couple of doctors, and they yell about insurance and the fact that they basically prescribe tests and everything because they're scared of being sued. And so first question, if you don't mind, I'll just go through a couple of them.
We'll take one or two, but I want to make sure everybody in the room has a chance.
Okay, well, I'll just run through the others. That was one of the major issues. But with the respect to the insurance companies are for-profit corporations that are looking out for their shareholders, i.e. they have to increase costs and cut back on expenses. The second, of course, as I mentioned, was the attorneys. And the third, I'm sorry to say, is Congress. I mean, Congress is more concerned with their reelection and basically having the insurance companies, the attorneys, everybody else has their hand in the congressman's pocket. So how can they look out for us?
Okay, panel, 3 tough topics. Anybody like to take on one or two of those? Charlie?
I'll try a couple. Mr. Lewis, thanks for your question. On the issue of malpractice reform, I happen to think it is an important issue, but I would disagree with my friends on the right. I don't think you're going to get a lot of savings out of that. One of our trustees at CED is Philip Howard, author of The Death of Common Sense and a couple other bestsellers. And Philip has been very active in promoting the concept of medical courts, specialized tribunals that will hear some of these complex cases where oftentimes medical evidence is complex, sort of like tax cases. And I think there's a lot of benefit to that idea, but I think it's an important reform. I would like to have seen it there. I don't think it's going to be a major driver. Just like medical savings accounts. I mean, again, my friends on the right see that as a panacea. It's not. It's an important aspect of reform. But on your final point, I do think that the money in politics system in this country is broken. At CED, we spend a lot of time on campaign finance reform, and we will continue to do that. We're going to become re-engaged in this issue, in large part because of the incentives created by the Supreme Court in the Citizens United case. But until we fix the way in which money enters our political system, and the fact that members of Congress have to spend a lot of time seeking PAC money, which in my view is it's either a tip or a bribe, and that's all it is. You're buying access. We're going to have these problems, and we have to come to grips with this as a country and free up our members of Congress and the Senate to represent the people and to legislate and to stop spending time raising money and with their hands out all the time. And some conservatives don't like that, but I actually think from a conservative perspective, these types of issues in campaign finance reform are important. They cut across the partisan divide, and they will change the way in which our elected members of Congress interact with the people. It's the people who vote. It's not companies and labor unions and PACs.
I couldn't agree more. I think that the campaign finance reform is critical and I think is part of the problem. I think one of the attempts at a bit of a solution to that was this independent payment advisory board. It took some of those decisions away from Congress, gave it to a board of experts and said, you make these decisions, tell us where the best place to save money is, and then give that to Congress. They have to make that an up and down vote. They can't be making deals. It has to be yes or no. So I think that's one way to address that, which hopefully in the meantime we can help to address that. And second, I would say with MedMal, the threat of medical malpractice, I think, is sometimes worse than the threat of it is worse than what really happens. And what we have seen in many cases, I think, is that the practice of defensive medicine becomes the excuse for ordering more and more tests. For example, we've seen in places like Texas, where they have tort reform, the practice patterns they're still practicing defensive medicine. So that's where we've got to change the payment reform, changing the way that they are incentivized to provide these things. And I hope that will end up changing the behaviors so they don't feel they have to do it just because they're going to be sued. I think there's lots of other creative ideas to look at this threat of malpractice. Some of them is just saying, I'm sorry. We've seen that works because it's the threat of the malpractice too. But I hope that's going to change some of that behavior.
I'm a recovering attorney. Between two physicians, but I have not looked at this matter. It's a constitutional law question. It will be litigated, and the courts will decide. I don't know where it's going to come out at this point, and I'm sure it'll go to the Supreme Court, which is in the process of flux as well. So.
I am not an attorney, but I can just say we've been working closely with the Constitutional Law Center. And from the investigations that we're doing looking into it, it doesn't seem like it's one of those things that's going to gain when it finally comes before the courts. It doesn't seem like the merits are going to be there. Again, I profess not to be an attorney, so I'm not sure. But you're right. There's a lot of action happening around the nation looking at this. But I think most people, when they're looking at the details, are thinking that it's not going to end up standing in court.
Sir, right here in front.
I'm Stuart Sloan, a retired lawyer. Recovering. I have two questions. The first addressed to the two doctors, which is that Mr. Kolb mentioned the Wyden-Bennett bill, which had bipartisan support. I would like an answer as to why the administration didn't pursue that further if they were interested in bipartisan reform. My second question has to do with the revenue and the costs. I'm a little confused. I understand the basic compact that in exchange for insurance companies eliminating the precondition clause and the lifetime cap, they would be getting the revenue from millions of uninsured people, many of whom are young and healthy, which would compensate for the additional costs of removing those two clauses. The question where I'm confused is where is the connection going to be from the premiums that will eventually be paid by the currently uninsured? How are they going to get to the private insurance companies that are going to actually suffer the increased costs? If they're going to exchanges, if the premium is going to exchange, are they the same companies? How is that going to work? And we saw an article in yesterday's New York Times that New York State premiums are predicted to go up drastically simply because of that shortfall in revenue, not compensating directly for the increased costs.
I'll just say a quick word about how the exchanges work. So the exchange creates a new marketplace, and in this new marketplace are private insurers. And in this private insurer, then, the new uninsured, young, healthy are going to be coming in there, but also those folks that previously did not have insurance, possibly because of the pre-existing condition. So they are private insurers. So it will be the Aetnas and the Blue Cross that will be within this marketplace. So we're buying into the marketplace, but that will be, and again, because it's state-based, each of these insurers are going to be reflective of the other insurers that are in that market. So they still think that it will compensate having the healthy younger folks in who traditionally did not buy into insurance while you're having those with the pre-existing conditions. So I would say that's how that's going to ultimately work in a very simplistic way.
What we do know, though, is that different insurance policies around the country cover different things. So at some point, for the risk underwriting to make sense, unless every insurance company suddenly becomes a nonprofit, there's going to have to be some balancing, I would think, of what's covered in light of what's being paid for. Someone's going to have to make those decisions, presumably on an exchange basis. I mean, just like OPM, I assume now oversees the content and the quality of the insurance companies that participate in the federal FEHB model.
And I'll add, the most real-time experience we have with this model is in Massachusetts, where we have a connector, which is the same type of gateway, whatever you want to call it, but it's basically an exchange for private insurance companies. And that's exactly what the board of the connector has to do, is set down what the minimum floor standards are, what benefits have to be covered to be part of any sort of exchange plan, but then also how those plans are enacted. And remember, this isn't just one plan fits all. You'll see tiering within these exchanges as well as a mechanism to recoup some of these costs. So in Massachusetts, we've got 3 tiers of benefits that can be provided as part of this exchange mechanism. And then I think I'm probably going to be the only person to deal with the Wyden-Bennett issue, and I'll tell you that that was actually the point in time when I transitioned from working in the Senate to the White House. And I can tell you that right now, any signal we sent in the Senate leadership to the White House or to the transition team was that Wyden and Bennett was not going to be a bill that was supported by a majority of, and I'm speaking from the Senate since those were the senators that put the bill forward, were not going to be supported by even a majority, in the word of 51 senators in the United States Senate. So I don't know, having said that, I'm positive that the administration in its formation heard that from senior legislators and thought, okay, well, this is not really an option that we're going to pursue, when in fact, at the time, I know Senator Wyden himself had met with every single senator in the United States Senate and had some of them on his bill in a bipartisan way. But what we saw behind the scenes was that even the supporters, including named co-sponsors of the bill, actually were starting to have doubts and were talking about not signing on to the bill in the new Congress. So there were a number of, I think, talking about the support of Wyden-Bennett beyond the fact that people signaled it as a kind of an indictment of the employer-based system is far-reaching, that the support really wasn't there when the votes were needing to be tallied.
Yeah, my reporting would bear that out as well. We're just about out of time, but we have a microphone over here, and then a couple folks will be able to stick around for an extra question or two. But yes, ma'am.
Okay, great. I'm Cynthia Butler. Thanks very much. What a beautiful room. Thanks for hosting this. It's lovely. I was wondering, a lot of the people on the left were actually really upset with the dropping of the public option single payer, and I think that's probably closer to what the French system is, and I think also analogous to the Swedish, which has really good longevity, and I think that's worth looking at. So my question is there any room left still for proposing anything new along those lines? Because one of the things that tipped some of the activists I know on the left over to supporting it was that they still were saying that there's a possibility that could move in that direction. And I just had another quick question, is have you looked at all on the costs of medical education? Because I know that people come out of med school now with a couple $100,000 in debt, and that's not like what happens in Europe, where the educational system at the foundation is subsidized.
Well, I'll spare the panel being on the hot seat on the public option single payer question and take a go, which is no.
And I'll tell you about the education piece. That's a huge issue, not just in our country, but it's in some of the other developed countries that have models with private pay in medical schools the way we do. So the medical the legislation